let's talk heart failure. And what is heart failure? Well, it's failure of the heart to do its thing. So we've got this decrease in cardiac output, decrease in stroke volume, and we're going to see a low ejection fraction. So what is an ejection fraction? Well, it's how much of that blood that's in your left ventricle. So if we talk about left ventricular ejection fraction, which we're really concerned about, how much of that blood is being squirted out to the body. Right? So how much blood are we actually being squirted into systemic circulation? So if your heart is failing, we're going to see a decrease in cardiac output, decrease in stroke volume, and we can measure that through ejection fraction. Pushing a little further, we are concerned with diastole, we're concerned with systole, we're concerned with ejection fraction in heart failure. So in diastole, that's when your ventricles are relaxing and filling with blood. In systole, that's when your ventricles are contracting and squirting that blood out to the lungs from the right side and to your body from the left side. And your ejection fraction is just the percentage of that blood in your ventricles that has been ejected per beat. We're going to see it as a percentage, and you know what? Just sitting here, my ejection fraction might be 70%, and that is completely normal. We're never going to completely empty our ventricles. So 55 to 75% is normal-ish ejection fraction, right? There are other factors to take into account, but sitting here, I would estimate, just feeling, just estimate, without an ultrasound machine and echo right here. Yeah, I'm probably my ejection fraction right now 70%. I feel fine. Once we get down lower and lower and lower, then we want to start treating, and we're going to start saying this is heart failure. Right? You've got a patient with an ejection fraction of 50%. Right, we're starting to see some heart failure. We're going to start to treat that. Once we get down below 20%, then we're talking pretty severe measures to treat this and really getting into heart transplant territory. Before we get to heart transplant, which is a pretty big thing, we're going to try to manage this. We're going to try to catch heart failure early on and manage it. And the goal here is to improve symptomology and increase overall survival, add years onto this patient's life. So that's the end goal of heart failure management. And medication wise, what are we going to use? We're going to use diuretics, we're going to use ACE inhibitors, angiotensin receptor blockers, your ARBs, we use beta blockers. We've talked about those already when we talked about especially hypertension, high blood pressure, and they're going to do similar things for your heart failure patient. So if you see these on their side table, well, what are you taking this ACE inhibitor for? It might be for heart failure, it might be for hypertension, it might be for both. But we've talked about these four categories and classes already, and then throw in a couple more. We've got aldosterone antagonists. We'll talk about digoxin a little bit and other vasodilators they may be on. Let's go back to this big kind of diagram, all this information in your face all at once, this renin angiotensin aldosterone system. And what we are focusing on now, instead of angiotensin 1 and ACE inhibitors and angiotensin 2, which we talked about when we talked about blood pressure regulation, let's talk about aldosterone. And that's all the way down here. So angiotensin 2 stimulates the adrenal gland to release aldosterone. Aldosterone goes over here, goes back to the kidney, and tells the kidney to reabsorb salt, reabsorb water, and to retain fluid. So, if I give an aldosterone antagonist, if I block aldosterone, then I am in turn blocking that sodium and water reabsorption. So they're diuresing, they're getting rid of salt, getting rid of water. I've got some sympathetic side inhibition. I'm getting some vasodilation, which is a great thing, and we're relieving stress on that failing heart. So we can't reverse heart failure, but we can improve symptoms and we can take workload off of the heart. Most common medication for aldosterone antagonists is going to be spironolactone. Might also be on digoxin. Digoxin comes from the foxglove plant, so it is naturally derived from a plant. Mechanism of action is going to increase stroke volume and contraction strength without increasing oxygen demand. So your heart isn't using as much fuel, but is pumping out a lot better, is working a lot more efficiently, and that's a great thing about digoxin. Um, Drawback to digoxin: very, very narrow therapeutic index. It's very easy to become toxic on digoxin. Even if you take your normal dose every single day, there are other things that you might have eaten. There are other conditions that you might have that cause your digoxin levels to go kind of go crazy, right? So, digoxin is pretty commonly prescribed, but these patients are going to be closely monitored, and their levels are going to be closely monitored. Some very common side effects with digoxin: a little bit of bradycardia, sometimes some visual disturbances, kind of a halo effect, visual disturbance that your patient will complain of. Maybe some nausea, vomiting. So these are just side effects, not necessarily signs of toxicity, but things we should be watching for. Once they get into their toxic state, hyperkalemia, because digoxin kind of messes with sodium, messes with potassium. It's easy to go hyperkalemic, and digoxin is just gonna, once we kind of go toxic with digoxin, we're gonna see some cardiac arrhythmias. And of course, about all of this, if you have any questions, comments, concerns, or cuss words, please let me know.